Hello, my name's Will McConnell. I'm a respiratory consultant at Dorset County Hospital, and I'm also the lead for the Dorset Respiratory Network and one of the leads for the Southwest Respiratory Network. And I would like to talk to you about the new NICE guidelines that came out in November 2024, which really provide a very new way of managing asthma, which hopefully will be very effective, not just at controlling people's day-to-day symptoms, but also preventing deaths, reducing exacerbations and admissions for people with asthma. And it involves new ways of diagnosing and new ways of managing asthma. Asthma deaths have been with us for years, and we've known about them for many years, but this was particularly highlighted in 2014 when the National Review of Asthma Deaths looked at all the asthma deaths in England over a year's period, and it showed that the deaths that did happen often were preventable. They often occur in the community, and they're very commonly associated with high SABA usage. You can see from the graph, the green graph on the right here, that the UK has asthma deaths which are worse than the average in the European region. Other places with lower rates of asthma deaths include places like Croatia, Portugal, Malta, Iceland. And there are countries that are worse than us with regards to asthma deaths, such as Turkey and Tajikistan, Kazakhstan. But one would have hoped that the United Kingdom, with its National Health Service, should be able to achieve better outcomes. The other graph shows how asthma mortality is associated with high SABA usage. So that blue line that's lower down shows those people who are using more than 11 SABAs per year, and you can see that their chances of dying is significantly higher. And this is a large study looking at hundreds of thousands of patients. The National Review of Asthma Deaths, as I mentioned, was published in 2014, and it was reviewed in 2022. And sadly, the review showed that not much had changed. This blue chart shows that the number of asthma deaths amongst the people who died of asthma, a large number of them were using 12 or more SABA prescriptions, 39% of them. And some even had over 50 SABA prescriptions per annum. And the other brown chart shows you the use of inhaled steroids, and the vast majority, 80%, had fewer than 12 inhaled steroids per year, and very many had fewer than 4. So inappropriate use of SABA and not sufficient use of inhaled steroids does seem to be associated with higher mortality. These graphs show the asthma mortality across the southwest of England, and you can see that the dark line shows the England average for mortality from asthma, and you can see most of the ICBs in the southwest are doing very well with low asthma mortality, apart from my own, which is Dorset, and you can see the asthma mortality in Dorset up to 2019, which is where this data goes up to, was higher than the national average, and that's bothered me for a long time as to why that might be. Now, I do have some data since 2019 which seems to have shown a significant reduction, so that we're now better than the national average in Dorset. And I suspect this might be related to the fact that a few years ago we adopted this new way of managing asthma, and so I'm hoping that our asthma mortality figures reflect that improved care. So this is the new NICE guideline, and I've selected a few key quotes really from it. Firstly, the NICE talks about risk stratified care, identifying those people who are particularly at risk of poor outcomes, including death. And as you can see there, non-adherence to medication, particularly inhaled steroids, overuse of short-acting beta-2 agonists, and repeated episodes of unscheduled care, particularly A&E visits and admissions, are all risk factors. And one of the key sentences in the new NICE guidelines is this one at the bottom: do not prescribe short-acting beta-2 agonists to people of any age with asthma without a concomitant prescription of inhaled steroid. And once you remember that, it changes how you manage asthma. In Dorset, we have the Dorset Insight and Intelligence Service, which is able to suck data out of the primary care record and present it in a very pleasing way. And you can see that in November 2024, this shows that we have 61,000 asthmatics in Dorset, and you can see the SABA inhaled count. So you can see from 0 to 12 plus, you can see how many people are getting each count of SABA inhalers. So you can see 3.1% of the population are getting 12 or more SABAs. And in fact, anything over 6 is generally regarded as SABA overuse. On the other hand, the bottom graph shows you the inhaled steroid count. And generally, we'd like people to be using, achieving at least 75% of their inhaled steroid use. Well, you can see that a significant proportion of the population are using much less than that in terms of inhaled steroids. So we've got a bit of work to do if we're going to try and reduce exacerbations. And you can see the other graphs there shows you the number of percentage of people with 2 or more prednisolone prescriptions, which sits at 9.4%. 2.7% have a respiratory admission, and quite a few have some attendance at ED. On the other hand, 80% of people haven't attended ED in the last 12 months. If we look at the 7 ICBs in the southwest, one of the interesting observations is that there seems to be quite a strong correlation between people's compliance with the inhaled steroids and the asthma admission rates for the population. So you can see Cornwall and Somerset have got a very high percentage of people taking 3 or more inhaled steroids per year. So we're somewhere about 68% or 70% in fact. Whereas around Bristol, BNSSG, the admission rates are significantly higher and the compliance rates are significantly lower at around 55%. And then the other 4 ICBs are somewhere in the middle. So that association may not be causal, it's just an observation, but biologically it's plausible, is quite powerful. We've done a similar look at within Dorset. We have 18 primary care networks in Dorset, and you can see that the admission rates, this is the percentage of asthmatics with at least one admission rate, varies from 1.2% of our asthma population to around 3.5% of the population. So an over doubling at the rate of admissions. And in fact, if Dorset, the whole of Dorset was as good as Sherborne in terms of asthma admissions, then we would have 56% fewer people having an asthma admission. The question is, what are they doing right in Dorset, in Sherborne? What we can see if we look at these 18 primary care networks, just as we did with the Southwest with the 7 ICBs, we can see once again a correlation between inhaled steroid use, this is the percentage of people using 10 or more inhaled steroids, and the chances of being admitted to hospital. So getting people using inhaled steroids more consistently would seem to be a good idea. So when it comes to the NICE guidelines and the diagnosis of asthma, the emphasis is on inflammation. And that actually is the whole message of the whole guideline. We must diagnose asthma on the basis of inflammation, and we need to treat that inflammation effectively. So we get a patient who's got a good history to go with asthma, wheeze, cough, chest tightness. Very often they'll have a history of atopy, they might have a family history, and we need to think about alternative diagnoses. And the message from the NICE guidelines is don't confirm a diagnosis of asthma without a suggestive clinical history and a supporting objective test. And previously we've tended to think about spirometry and reversibility as the primary diagnostic test for asthma, but now we're going to shift is to look for inflammation, particularly at FeNO, and FeNO is the test that we really would like, so an exhaled nitric oxide to look for evidence for eosinophilic inflammation in the airways. Alternatively, a blood test to look for raised eosinophil counts is the other one that they advocate as a first step. Now, it may be that those things aren't available at diagnosis, and the trouble with not using them immediately is that they will tend to be become less useful if you've started an inhaled steroid and controlled the asthma. And therefore, if those aren't available, those tests, then perhaps a peak flow chart and charting the improvement with treatment would be a useful test to do. Alternatively, there's an FEV1 with reversibility, but often the waiting times for that are even longer than for FeNO. FeNO is a relatively new test to the NHS, but it's been around for 20 years or more. And it's a diagnostic tool for asthma, but it can also be used as a marker of risk and poor control because people without raised FeNO tend to have higher exacerbation rates. And it can also be used as a therapeutic target. So you can measure people's FeNO and say, well, let's try and get your FeNO down so that your symptoms improve. And the best way to get FeNOs down is by giving people inhaled corticosteroids. Asthma is not the only condition that can increase the FeNO levels in your exhaled breath. In allergic rhinitis, it may come from the nasal airway. It can also be increased in rhinovirus infections, and certain dietary consumptions can put your FeNO levels up. On the other hand, there are things that can reduce FeNO levels, such as smoking, and certainly if you control the asthma and start an inhaled steroid or give people prednisolone, then the FeNO comes down very smartish. So it means that it's not 100% sensitive and specific test for asthma, but if we used a cutoff of 40 parts per billion, then about 20% of people with a positive test don't have asthma. On the other hand, there are 20% of people with a negative test do have asthma. So we can't look only at the FeNO when considering the diagnosis of asthma, but with a suggestive history and a positive FeNO, that's strong support. So this is what NICE are suggesting for adults: an eosinophil count greater than your local upper limit of normal. For most places, that is 0.4. So if you've got an eosinophil count of greater than 0.4, that's evidence for there being likely to be asthma. Alternatively, a FeNO level of 50 or more parts per billion suggestive of asthma. Now, if one of those tests doesn't confirm asthma, but the history is reasonably consistent, then that's the time when to move on to spirometry with reversibility, and we're looking for a 12% increase in FEV1 or 200 mils. And if that still doesn't confirm asthma, but your suspicion is significant, then it's worth referring the people for a bronchial challenge test, but that will generally only be done in secondary care. For children, the cutoffs are slightly different. The FeNO cutoff is greater than 35, and the suggestion, if FeNO and FEV1 don't confirm the presence of asthma, then it's worth checking skin prick tests, measuring IgE or blood eosinophil count. When it comes to treating asthma, the main message of the NICE guidelines is that we should not be giving out salbutamol anymore, and we certainly shouldn't be giving it on its own without an inhaled steroid. What they're suggesting as an alternative is that we use an inhaler which contains an inhaled steroid and a bronchodilator, and specifically the fast-acting long-acting bronchodilator formoterol. So you can use these inhalers both as your preventer and as your reliever. And there are several that are available. I've shown you some diagrams here of the ones that are available in Dorset, but there are other ones that may be available in your ICS. And of the ones that are available for this type of regime, Symbicort probably has the strongest evidence base and has been around for longest. But then you've got Foster, which contains beclometazone instead of budesonide, but it's also got the formoterol, and that comes as a dry powder inhaler, the Nexhaler, as well as the MDI. And the other inhaler you can see there is called Fobumix, which contains budesonide and formoterol. The evidence, the reason why it's important to differentiate formoterol containing ICS LABAs from salmeterol containing ones, or ones containing other long-acting beta-2 agonists, is this: because Foster bronchodilates much more quickly than the other long-acting beta-2 agonists, and it bronchodilates as fast as salbutamol. So it gives you that relief that you would get from salbutamol. So you can use it as your reliever. So the thing that's new to this regime is what we call the air regime. The fact that you can use ICS formoterol inhalers as your only inhaler, and you can just use it as required. So you don't need to use it regularly. For several years, we've had the MART regime available, which is where you use ICS formoterol both as your maintenance treatment, 2 puffs twice a day or something like that, plus as required as your reliever. But these studies from 2018 and several others have shown that you can use an ICS formoterol inhaler on an as required basis. So this is called the AIR regime. It's known, AIR stands for anti-inflammatory reliever therapy. And what this graph shows, what they did here was they did a 52-week study of people whose asthma wasn't controlled on SABA as required, or was controlled on low-dose inhaled steroid, and they randomized them to either having SABA alone or ICS formoterol alone. But there was another arm which also looked at people who were on regular inhaled steroids. And what they found here, and you can see the blue line on these graphs is the SABA alone. And you can see the exacerbation rates were significantly higher with SABA alone. And so we should be using this ICS formoterol inhalers as required for people who would not traditionally have been treated with SABA on its own. The black and the red lines are identical, and those show the regular inhaled steroid group compared with the ICS formoterol group, and you can see that their outcomes in terms of exacerbations was the same. But importantly, they managed to achieve that control in the ICS formoterol group with a much lower dose of inhaled steroid, and that's quite important. So you can achieve just as good control in terms of exacerbation rates with the ICS formoterol. And they've done a Cochrane review on these quite a lot of studies that have now been done using this AIR regime, and found that if you compare the AIR regime, ICS formoterol as required, compared to SABA on its own, you'll see that whilst most people, the green faces, do not have exacerbations, because these are people with mild asthma, a significant proportion of people on SABA alone do have exacerbations. Those are the red faces and the yellow faces. But if you put them on ICS formoterol alone, then the yellow faces will not have an exacerbation over those 52 weeks. So you're reducing exacerbation rates considerably. So severe exacerbation rates are reduced by 55%, and asthma admissions and ED visits reduced by 65%. So that's why we're saying that SABA on its own really shouldn't be used nowadays. And this is the Cochrane review comparing the air regime with people with regular inhaled steroids. Now, clearly the difference is much less because you're comparing it with people whose asthma is well controlled with inhaled corticosteroids regularly. But even compared to regular inhaled steroids, the air regime shows an improvement, and you can see there are yellow faces there whose exacerbations would be prevented by using an air regime, with severe exacerbations reduced by 21% and asthma admissions and ED visits reduced by 37%. And the important thing is that the total inhaled steroid dose is less than half if you use the air regime. So in practice, what should we do about this? Well, we're talking about people aged 12 and over. So for children under 12, then the NICE recommendations are different, but children aged 12 and over, you can use the air and the MART regime. So if you've got mild asthma with intermittent symptoms, then it's good to use PRN ICS formoterol. If you have more persistent symptoms, then put them on the MART regime. And the MART regime can be ICS formoterol 1 puff twice a day, or it could be 2 puffs twice a day. So that's called low dose MART or moderate dose MART. And then on top of that, you can have your extra PRN doses as the symptoms dictate. So the options, as you can see there, for if you want a meter dose inhaler, then Foster has a MART license. If you're going to use it for air, and there's no reason to think that it wouldn't work for air, it's got a formoterol in it and it's got an inhaled steroid. It just doesn't have a license for it because most of all the studies have been done for air using Symbicort. But Foster you can use up to 8 puffs a day. For dry powder inhalers, you've got the Symbicort 200, which has got a license for air and MART, and you can use up to 12 puffs a day for that. You can use the Foster Nexthaler for MART, Fobumix that has a MART license, and those are up to 8 puffs a day. What you can't use is the salmeterol containing inhalers, Relvar, Seretide, and certainly not the triple inhalers Trimbo and Trelegy, because you don't want to be giving extra doses of long-acting anticholinergics in those triple inhalers. Now, there are, of course, the usual asthma treatments that are available. The NICE guidelines haven't recommended the use of theophylline. I think theophylline are now generally regarded as of little value in asthma when compared to all the other treatments that we have to offer. But if you've got somebody who's on a moderate dose MART regime and they're still symptomatic, particularly if they're still having exacerbations, then you would add in montelukast. You might trial a long-acting anticholinergic such as the tiotropium respimat. And if their exacerbation rate is more than 3 or more per year, those are the people who should be being referred to secondary care to consider a trial of a biologic injection. And they're very effective at controlling asthma in people who exacerbate significantly. Now, we do have fixed dose inhaled steroids where you would give LABA with an ICS such as Relvar, or triple inhalers such as Trimbo, and there's Trimbo, the lower strength one, 87, or the 172, the high strength one, and then there's the Enerzair Breezhaler. So these are all fixed dose inhalers where you'd take 2 puffs twice a day, and those people would have to have a SABA to give them relief. So by and large, I think we should be trying to avoid those and trying to use the MART regime, which on balance for most people will be a better option. And when we're adding these treatments, so increasing the dose of inhaled steroid, adding in montelukast, adding in anticholinergics, it's really important that we review the patient 8 to 12 weeks later. Firstly, to see whether our treatment's been effective at all, because there's no point continuing with treatments that aren't effective at all, but assessing whether they've had a sufficient effect, because if they're still exacerbating, then that's the time to think about referring people for biologics. And it's worth checking their pheno again in these sort of people who exacerbate quite a lot to see if that airway inflammation is being successfully controlled with their inhaled steroid. So if you look at our 100,000 people in Dorset who are coded with an asthma diagnosis, now these are people who've ever had an asthma diagnosis in their System 1 record, actually 42% of them have had no inhalers in the last 12 months. So essentially they don't have active asthma at all. We can forget about them. We've got 7% who are on SABA alone. Now, those people may not have asthma at all. They may be breathless for other reasons. They may be overweight. They may have COPD or something like that. So for those patients, I think it's worth checking their diagnosis to make sure they do have indeed asthma and doing an objective test if needs be. And then those are the people where I think we should be aiming to get them onto an air regime. We then have these people who have asthma, which is well controlled on regular inhaled steroid, and it's reasonable for them to continue on their current treatment using SABA as their reliever. But I think it would be reasonable at their annual review to offer them an air or MART regime, because it may be that they don't need quite so much inhaled steroid and they could be managed on a much lower dose and still not have significant exacerbations. So, and that's 39% of our asthma population. And then we've got people whose asthma isn't well controlled for some reason. So they may be the people who are SABA overusers and they're not exacerbating. They may be people who exacerbate a lot but aren't overusing SABA, and they may be the people who exacerbate and they overuse SABA. Certainly the exacerbators, I think they're it would be very good to offer them MART. SABA overusers are more tricky because often people overuse SABA not because their asthma is poorly controlled, but because they're breathless for some other reason. So with SABA overusers, often it's a matter of educating them about managing breathlessness in a different way. So that shows you the way we could shift our asthma population onto these new regimes. These are the draft new Dorset asthma guidelines. We adopted the air regime as part of our guidelines in 2022, but all we've done is we've shifted it to the top. So there at the top we've got the air regime. And then as people's asthma becomes more severe, we move to the right with low dose MART, then moderate dose MART, and then adding in other forms of treatment like montelukast tiotropium. And then the traditional regimes are still there as an option, using dry powder inhalers or meter dose inhalers, but we're favouring the air and MART regimes now. And on the back of the guidelines, we've got details of making a diagnosis and how to monitor asthma. So in summary of what I've said so far, in confirmed asthma, SABA monotherapy, shift from the air regime. If they've got asthma isn't well controlled, firstly think about low dose MART, which is 1 puff twice a day essentially, or medium dose MART, 2 puffs twice a day. And if they're still exacerbating and they've tried luteinizing receptor antagonists and LAMAs, then refer to a specialist. And it's difficult. One might think, well, surely SABA is very cheap and ICS formoterols are much more expensive, and that is true. But if you're controlling asthma better with that, then it may be that this is going to be a cost-effective move. And certainly if we're using lower doses of inhaled steroids, then it may be that even though inhaled steroids on their own, like Clenil and Qvar, are quite cheap, if we're using fewer inhalers, because we've got using ICS formoterol, you may actually find that there's a significant cost saving there. So there's the potential for cost savings, certainly if you're reducing admissions to hospital, where a lot of the cost is going to reside. So what we need to be planning to do is increasing the use of pheno in the diagnosis of asthma, If you see a new asthmatic, start them all on air or MART, depending on what their initial symptoms are like. And for pre-existing patients, SARBA alone becomes ICS formoterol, PRN, air regime. Trial the MART for poorly controlled asthmatics, and then offer air to those who are well controlled on ICSs. So this is what we're suggesting with new asthmatics. So if you see in your surgery somebody who's presenting with a good history of asthma, then try and get an objective test done. Try and check for eosinophils. Try and do a pheno. If you've got a pheno in your surgery, it's much easier to then that day get a pheno done, and that will confirm the diagnosis for you. If you really haven't got access to those imminently, just give them a peak flow meter and peak flow chart, and then start some treatment and see how they improve. You may want to do a chest X-ray if there's doubt about the diagnosis, to look at other causes for breathlessness. Then you've got the basic stuff: stopping smoking, immunizations, make sure they can use the inhalers, and then start them on one of these inhalers. Don't give them a SARBA. Give them one of these formoterol containing inhalers. And if they're significantly bad, give them a course of prednisolone. And then in Dorset, what we're trying to do is have a real drive on educating patients about asthma, because one of the problems with asthma and COPD is that we have traditionally not really educated people about them, and there are quite a lot of people out there who go around puffing on inhalers and don't know why they're doing it. They just use it for their breathing, as they say. Whereas if we diagnose diabetes on somebody, we'd teach them about it. And we've got a number of options. We're trying to set up some face-to-face group sessions so that we can call together all the 12 all the asthmatics that have been newly diagnosed over the last 12 months, or perhaps 3 months, depending on how many are being diagnosed, and get them all and do a group session with them to teach them about asthma face-to-face. On the other hand, we have access to Respiratory Connect, which is a service run by Asthma Lung UK, where newly diagnosed asthma and COPD patients get 3 phone calls over a couple of months from an Asthma and Lung UK team if they want it. And then we're currently adopting a new digital app to help people learn about their asthma. So teaching people early on about their asthma and COPD is really important. And if you see a patient who's got an exacerbation, so if you see somebody who's just using SARBA and they exacerbate, well, it's really important that we get them onto a MART regime. And if they exacerbate and they are on normally on regular inhaled steroids, then switch them over to MART and then review them 3 months later. How we get people onto this new regime depends on how enthusiastic you feel about getting this done. What we could do is wait for the annual review and shift our patients over at that stage, and that probably is the most the least challenging way of doing it. I'm quite keen that we get people onto off SARBA alone quite quickly, so I'd quite like to identify those people on SARBA and get them over before their annual review is due. And I'd certainly like to get those people who are getting high exacerbation rates reviewed earlier than they're waiting for their annual review, so that we can get them onto proper treatment and, if necessary, get them onto a biologic to control their asthma. But certainly as part of the annual review schedule, I would recommend that we use those opportunities to get people, to shift people onto the new NICE guidelines. The other consideration, of course, when looking at which inhalers to give people is their carbon footprint related to the different inhalers. So at the top, we've got those ones which we're really trying to avoid: Flutoform, Symbicort, MDI, which contain have a high carbon footprint. At the lower part of the graph are the dry powder inhalers, which have a far less environmental impact, or the Respimat is the other inhaler that is very good. And then in between, we're trying to desperately to avoid salbutamol Evohaler, the Ventolin Evohaler, because that has a much more environmentally adverse impact compared to other SARBAs such as Salamol or Aramir. But ideally, we wouldn't want them on SARBA at all. And so this is another opportunity to get people off SARBA so that their asthma is better controlled and we have a better impact on the environment. So it's worth looking at the NICE guideline. There's a bit more detail and it'll tell you a bit more about what to do in children. There are some nice charts like this as part of the NICE guideline, and I think it's worth laminating them and putting them on the walls of your surgery to help. So this is looking at the objective testing for asthma using FeNO and spirometry. This is for children aged 5 to 16 with different cutoffs from the adults. This shows you the MART and the AIR regimes for people over 12, and this one shows you the pharmacological management for asthma aged 5 to 11. So it's worth looking at that when thinking about children, and then under 5, which of course is a much more difficult issue when it comes to the diagnosis and management of asthma. So conclusion, firstly, ensure that an asthma diagnosis is backed up by an objective test, ideally FeNO or eosinophil blood test at presentation. Don't start any new asthma patients on SABA, and certainly not SABA alone. What we should be doing is prescribing an ICS formoterol inhaler as a reliever and a preventer. For mild asthma, use the AIR regime where they just use their PRN ICS formoterol. If they've got more significant persistent asthma, then the MART regime is the right one. 2 puffs or 1 puff twice a day plus PRN of ICS formoterol. And then add montelukast and tiotropium if they're still not well controlled. And if there are 3 or more exacerbations per annum in spite of maximum treatment, in spite of us checking that they're using their inhalers properly and all the usual things and make sure their comorbidities, their rhinitis is well controlled, then we should be referring them for assessment for a biologic, which are normally very effective at controlling severe asthma. Thank you for listening.